Welcome to this explainer presented by Dr. Christophe DeLong and Connexa Formation. Today we're diving deep into the art of proprioceptive neuromuscular facilitation, or PNF for short. We're looking at a clinical synthesis that sits perfectly right at the intersection of hardcore neurological science and pure clinical finesse. Honestly, whether you've been a physiotherapist for decades or you're just looking to refine your manual therapy skills, the insights we're covering today are absolutely going to change the way you interact with your patient's nervous systems. So, here's the million-dollar question. How can you, as a therapist, maximize your patient's range of motion and strength? And I don't mean over the course of weeks or months. I mean in mere seconds, right there in a single session. I know, it sounds like a pretty lofty promise, doesn't it? But what we're looking at today isn't magic. It's just deeply rooted neurophysiology. By knowing how to properly hack reflexes, muscle spindles, and Golgi tendon organs, you can unlock some truly immediate gains. All right, here's our roadmap for this explainer. We'll be hitting 5 key areas: strengthening and motor control, the crack technique, optimal resistance, manual contact, and finally, the power of words. Let's kick things off with Section 1, strengthening and motor control. Okay, picture this. You're using the repeated contractions protocol. Your patient is performing a movement, but right in the middle, the muscle just gives out. Maybe they're sitting at a 2 or 3 out of 5 on the strength scale. They've hit that weak point. Now, instead of just stopping and resetting, you, the therapist, detect that exact moment of weakness and instantly apply a quick stretch to the muscle paired with a sharp, loud command like, again, push. This is the neurological hack right here. That quick stretch stimulates the neuromuscular spindles, and boom, you trigger a myotatic reflex. This creates a sudden, involuntary burst of extra contraction, which literally helps the patient push right through that weak zone. You just repeat this 2 to 3 times in the same continuous movement, essentially bridging the gaps in their strength. It's incredibly effective. But hold on, understanding exactly when to deploy this tool is absolutely critical. It's fantastic for marked muscle weakness where they just can't finish the full range, or for the rapid fatigue you see in neuromuscular pathologies like MS or myasthenia. It's also a go-to for post-immobilization atrophy. However, and this is a big however, there are strict contraindications. You must never, ever use this quick stretch technique if the patient has spasticity, acute pain, active inflammation, or a recent fracture. Applying a quick stretch to a spastic muscle, yeah, that is a recipe for clinical disaster. Building on that, once your patient finally nails a successful movement, even if it's just a partial one, you've got to use the replication technique. This means having them repeat that exact successful movement immediately. And by immediately, the protocol literally means within 2 seconds. Why 2 seconds? Because you are actively capitalizing on short-term neurological facilitation and post-tonic potentiation. Their motor memory for that specific neural pathway is wide open right then. So by commanding, again, do exactly the same thing. Within that tiny 2-second window, you are aggressively wiring in that new neuronal pattern. Moving right along to Section 2, the crack technique. So CRAC stands for Contract Relax Agonist Contract, and it is pretty much the absolute pinnacle of stretching protocols. Let's walk through it. Say you're working on hamstring flexibility. Step 1, you bring the leg up to its maximum current amplitude and hold it there for 10 seconds. This allows for tissue adaptation. Step 2 is the contract phase. The patient pushes their leg down against your maximum resistance for about 5 to 6 seconds, which fires up the Golgi tendon organs. Step 3, they completely relax for 2 to 3 seconds. This is your golden window of autogenic inhibition, where the hamstrings are neurologically inhibited by their own GTOs. Now, Step 4, the agonist contract. This is the game changer. The patient actively lifts their own leg further up for 3 to 5 seconds while you just lightly facilitate. This adds reciprocal inhibition into the mix, meaning the contraction of the hip flexors further shuts down the hamstrings. Finally, Step 5, you consolidate that brand new range of motion for 10 to 15 seconds. And if you're sitting there wondering why we bother going through all those meticulous steps, just look at this data. This compares the average range of motion gains across different stretches. Your standard static stretch gets you about 8 degrees of gain. Hold relax gets you a respectable 11 degrees using just autogenic inhibition. But CRC yields a massive 18-degree improvement on average. Because it perfectly stacks both autogenic and reciprocal inhibition, it is for sure the undisputed heavyweight champion of ROM gains. Let's jump into Section 3, optimal resistance. You know, the term maximal resistance in PNF is actually kind of misleading. If you give 100% resistance, you create a complete block. The patient literally can't move, which just leads to frustration and pain. On the flip side, 0% offers no challenge, so you get zero neural irradiation. The real art here is finding that optimal sweet spot right in the middle, somewhere between 40% and 85%. Optimal resistance is the absolute greatest amount of resistance you can apply while still letting the patient smoothly and completely finish the movement. And remember, this is a dynamic dance. You might give 80% at the start where they're strong, drop it down to 60% in their weak mid-range, and then dial it back up to 80% at the end. The golden rule: resist where the patient is strong, facilitate where they're weak. And guys, the direction of that resistance is everything. The correct way is applying resistance directly opposite to the desired movement, staying perfectly aligned with the diagonal pattern. The incorrect way? Applying lateral or oblique resistance. If your ankle is off by even a little bit, you literally pull the movement off its intended neurological trajectory, and you completely ruin the effectiveness of the pattern. This is why your body posture as a therapist is absolutely crucial. Keep your base wide, use your body weight instead of just your arms. That's how you maintain that perfect, unwavering alignment. All right, section 4, manual contact. It's a really simple quote, but it's the bedrock philosophy of PNF. The therapist's hands are their best tools. Your hands aren't just there to push weight around, like you're at the gym. They are an intricate, highly sensitive communication system between your nervous system and your patient's. In fact, every single time you lay hands on a patient during these protocols, you are simultaneously performing 4 critical functions. 1, you're physically guiding the direction of the movement. 2, you're applying that perfect 40 to 85% optimal resistance. 3, you are feeding vital sensory and proprioceptive information directly to the patient's skin and underlying receptors. And 4, your hands act as profound nonverbal communication, letting them know they're safe, establishing timing, and signaling intent. Now, to actually nail all 4 of those functions, your grip matters immensely. You should always use a broad contact. We're talking about using your entire palm in a lumbrical grip. This spreads the pressure out nicely so it's comfortable, but more importantly, it gives vastly superior proprioceptive feedback to the patient's brain. You have to avoid point contact at all costs. Grabbing them with your fingertips like a claw is uncomfortable, it can cause bruising, and it just sends totally confusing sensory information to their nervous system. Oh, and a quick pro tip straight from the source material: when you're working the upper limb, never grip directly on the elbow joint or you will completely lose control of the arm's rotation.
Finally, section 5, the power of words.
So ask yourself this: as a clinician, do you actually believe that the specific words you choose and even the volume you use can biologically alter your patient's physical muscle activation? I'm not just talking about hyping them up or making them feel motivated. I mean hard, measurable neurological output. Well, the science says yes. Proper use of verbal commands in PNF has a clinically proven neurological impact. Studies actually show that when you use precise, properly timed, and correctly intonated verbal commands, you increase EMG muscle activation by 15 to 30%. That is huge. Your voice is literally a facilitation tool, exactly like your hands. It improves motor unit synchronization and helps completely bypass psychological fatigue. So what does a perfect verbal command actually sound like? First off, it has to be clear and incredibly concise. We're talking 3 or 4 words maximum. Instead of rambling, "Okay, now I want you to try and push your arm up," you just hit them with "push up hard." Boom. It needs to be positive. Tell them exactly what to do, not what to avoid. It has to be direct and imperative, no conditional freezing. And the timing needs to be rhythmic and flawless. You give a preparatory command to warn them, an action command that fires the exact second your hands apply resistance, and then rhythmic encouragements to keep them grinding through the full range. Which brings us to the ultimate takeaway of this explainer. True mastery of PNF isn't just about memorizing the steps of the CARC protocol or the timing for repeated contractions. It's about holistically integrating that strict neurophysiological science with the nuanced art of your manual touch and the rhythmic, commanding power of your voice. When you get the science and the art aligned, the results you see in your patients are going to be immediate and profound. So, I'll leave you with this final thought. Knowing what you know now about hacking the myotatic reflex, utilizing dynamic resistance, and getting that free 30% EMG boost just from your vocal commands, are you ready to completely transform your hands and your voice into your absolute best therapeutic tools the very next time you step into the clinic? Take these concepts, put them to work in your next session, and just watch how fast your patients progress.